to ensure that student nurses are better prepared to meet the needs of people and families with disabilities, both in the community and as they access care in long-term and acute care facilities. We also would like them to be collected, the data collected on people with disabilities just like any other people, so that we can understand their aging, their lifespan, understand what's normal. You know, in health, we learn what's normal, and then we learn how that varies. And there's a lot of conditions that we don't understand how that syndrome would age, and we need to understand that better. And we also want to include everybody in health promotion activities, and but most of all, teach the nurses better ways to interact with people who are non-typical. So I'm here, and I also have a personal interest in people with disabilities. I have a daughter who, unlike some of the people I met tonight, have children with disabilities, and it's a long road and it's a hard road. And I'm going to read a story to you, and some of you I'm sure have heard it and others may not have, but it's a mother's story about how it is to live specifically with children with disabilities, and this is developmental disabilities. I'm often asked what it's like to raise a child with a disability, and to try to explain what it feels like and what my journey has been. You know, when you're going to have a baby, it's like having a fabulous vacation trip to Italy. You buy a bunch of guidebooks and you make your wonderful plans. The Colosseum, the Sistine Chapel, gondolas. You may learn some handy phrases in Italian, and it's all very exciting. After several months of eager anticipation, the day finally arrives. You pack your bags and off you go. Several hours later, the plane lands. The stewardess comes in and says, "Welcome to Holland." Holland, you say. "What do you mean, Holland? I signed up for Italy." I'm supposed to be in Italy. All my life, I have dreamed of going to Italy. But there's been a change in the flight plan, and they've landed in Holland, and that's where you're going to stay. The important thing is that they haven't taken you to a horrible, disgusting, filthy place full of pestilence, famine, and disease. It's just a different place. So you must go out and you must buy new guidebooks, and you have to learn a whole new language. And you will meet with a whole new group of people you would never have met. It's just a different place. It's a slower pace than Italy, less flashy than Italy. But after you've been there for a while and you catch your breath, you look around and you begin to notice that Holland has windmills, Holland has tulips, and Holland even has Rembrandts. But everyone else you know is busy coming and going from Italy. And they're all bragging about what a wonderful time they have there. And for the rest of your life you will say, "Yes, that's where I was supposed to go. That's what I had planned." And the pain of that experience will never, ever, ever go away. The loss, I always have trouble with this. The loss of that dream is a very significant loss. But if you spend your life mourning the fact that you didn't get to Italy, you will never be free to enjoy the very special, the very lovely things that are in Holland. You know, another mother wrote about this story on the internet, and she said, you know, having a special family with a disability is not just a little detour in life. It's not like taking a wrong turn and being delighted to find an awesome coffee shop around the corner. It's like everything you need and want to do in Holland is 10 times more difficult and costly than it is in Italy. No matter what you do in Holland, you feel completely sometimes alone, and you feel like you stand out like a sore thumb. And you just know that you would have blended in really well had you gone to Italy. Not to mention, it is not a vacation. You don't get to leave and go back home someday. The life you knew before and that you envisioned for your family is gone. And you are in a new life forever. And sometimes raising a child that's atypical is lonely. It can be lonely. And it can be really lonely when you go for health care and you expect professionals to understand. And when you end up comforting the professionals because they're uncomfortable, that's a real problem. But it's not the professionals' fault. A lot of times they were never prepared to interact and to make you feel comfortable. So my hope and desire is that we'll have nurses go out there and not just learn about differences and learn that, boy, the mind is an amazing thing. People don't have to walk to be amazing people. They don't have to talk to be amazing people. We want our healthcare providers to be able to understand that and to be able to understand when you go to an emergency room that it's just the whole family that needs to be treated. So I am especially delighted to have this program today. And Dr. Edwards approached me about this. I didn't approach her. And I give her a lot of credit for someone who is just, you can't stop her. She's like the Energizing Bunny. So let me turn this over to Allison and thank her so much.
Okay. Actually, I'm missing some of my papers. Dean Fraser, did you grab? Good evening. Thank you all for taking time out of your Thursday evening to join us with this very important discussion about disabilities, intellectual and developmental disabilities. I want to thank Dean Fraser for sponsoring the event with our appetizers. They're lovely, and George. And I also want to recognize Kevin Kern, who is the Chief Program Officer here at the Center. And thank you to the Center. Let's give a round of applause for sponsoring. Kevin, would you please stand and wave? Kevin and I have worked together for the last 4 years as I've brought community clinical students, nursing students here, and he's always so receptive. And we always, together we brainstorm about ideas. Sometimes I come up with ideas, sometimes he comes up with ideas, but we always have grand projects and endeavors when we work here at the Center. So at this time, I'm going to tell you a little bit about the format of this evening. We're going to have 10 fabulous panelists, and I can't thank all the panelists enough for coming tonight and talking about the various issues in healthcare and disabilities. I have structured questions that I'll ask the panelists, and the panelists will we have one microphone to pass amongst the panelists. So panelists, if you feel comfortable answering the question, please take it. You can raise your hand and we'll pass the microphone amongst yourselves. Just know that the microphone only projects to the video that we're videoing, but not really to the audience as well. So do project your voice, please. After we have the structured panel questions, then we'll turn over questions to the audience. And I have 4 of my wonderful community clinical students here who thankfully helped me this evening. They've helped set up, and they'll also help with collecting questions from the audience, and we'll let the panelists who feel comfortable taking those questions take those questions as well. So at this time, I'd like the panelists, I've seated you in alphabetical order from the left to the right, if you'll come to the stage, please. And then I'll introduce you. Okay, so I'm going to introduce the panelists beginning from left to right. Our first panelist, Susan Connell, is a CPA and also a parent advocate. She has over 25 years of financial management experience. She serves as president currently of the Looper Family Office. She has 2 children, Paige, 17, and John, age 11. John was born with Down syndrome, and she is grateful for the many blessings and challenges associated with parenting. Thank you, Susan. Lex Frieden, who unfortunately is in a wheelchair in the back of our room, is a rock star of the American Disabilities Act, and our lovely, thank you, Lex, Thank you so much for being here. Lex is a professor of biomedical informatics and physical medicine and rehabilitation at UT Health Houston. He also directs the Independent Living Research Utilization Program at TIER. And he was instrumental in conceiving, and drafting the Americans with Disabilities Act of 1990, and has received 2 presidential citations for his work in the field of disability. So thank you, Lex, for being here. And now seated next to Susan is Dr. Jordan Camere, who I've just recently come to know. She was actually, she got her baccalaureate degree from the University of North Carolina, where she also served on the soccer team there. And then she got her master's from UC Berkeley and followed her MD at University of NC, so she went back. She is she is faculty at the Center for Transition Medicine, and that's at Baylor College of Medicine, and we're hoping to take our nursing students there when we develop our scholarship program. She provides medical care and social support services to the growing population of adolescents, young adults with chronic childhood illness or disability as they move from pediatric to adult health care, including spina bifida, cystic fibrosis, sickle cell disease, congenital heart, autism, ADD, ADHD, Down syndrome, cerebral palsy, long-term cancer survivors, and other genetic diseases. Thank you, Dr. Camere, for being here. Ashley Kress and her son Blakely are here this evening. Ashley is the development director at the Rice School of Houston. She's been there for the past 12 years. And before that, she was a high school and middle school social studies teacher. She graduated from Rice with a bachelor's and a master's. She's a proud parent, and she also, her husband Hugh, she has 2 sons and a daughter in college. And seated to her left is her son Blakely Kress, who is a student at Memorial High School. He's a senior. He's hoping to go to Clemson University, and he also volunteers both at the Rise and here at the center. Thank you both, Kress family, for being here. Casey Pavelka is a medical assistant, UT Health Department of Orthopedic Surgery. She's seated here in the middle. While she was attending Texas A&M, she was involved in a motor vehicle accident that resulted in the amputation of her right arm. In 2014, she was then hired by UT Health Department of Orthopedic Surgery, where she began to work with Dr. Melton and the TIER amputee program. Since then, she's become a certified peer visitor trainer, a certified PALS trainer, which is a promoting amputee life skills trainer, a national nonprofit that also provides resources to the amputee community. She serves as a peer to patients, both in acute and rehabilitation stages of their journey. Thank you, Casey. Next, we have Jason Patrician. He is the Director of Outpatient Medical Operations at TIER. He also served in the U.S. Army Medical Corps. He has worked for nearly 20 years in diverse settings such as OT, laboratory, ambulatory care, home care, multiple unit physician practice, and nursing. He's a graduate of George Washington University and UT School of Nursing. He holds certifications in executive leadership, case management, and rehab nursing. Thank you, Jason. Richard Rosenberg is General Counsel for US Sync. He's also a parent advocate. Richard joined US Sync in April of 2008 and was charged with setting up the company's legal department. He has more than 28 years of professional experience in both accounting and law. He also has expertise in handling a wide range of business issues from legal to social responsibility. Richard is a cum laude graduate from Tulane, and he also earned his law degree with honors from UT Hookham. And Richard is currently the president of the Board of Governors for the center, an organization here which provides long-term care and support and vocational services for adults with intellectual and developmental disabilities. His oldest child, that also shares my name, Allison, is seated in the back. Wave your hand at Allison. Has lived here at the center for 6 years. Thank you so much, Richard, for being here. And Jamie Shear. Jamie is an occupational therapist with Memorial Hermann Woodlands. She's also a parent advocate. Jamie graduated cum laude from Rice University with a bachelor's degree in psychology and from Texas Women's University with a master's degree in occupational therapy. She has 5 children, ranging in age from 25 to 15. She also has 15-year-old twins, Jordan and Shiloh has Down syndrome. Thank you so much, Jamie, for being here. And seated here to my right is Lisa Schott, Human Resources Director for Association of Advancement of Mexican Americans. Lisa has championed disabilities, physical and mental health care throughout her career. She serves as the board secretary for the Center Serving Persons with Developmental Disabilities and is also involved with the Brenham State Supported Living Center in Brenham, where her son with profound developmental disabilities resides. Lisa has over 20 years of senior level human resource experience in disabilities, healthcare, and education sectors. Thank you, Lisa, for being here. Okay, so panelists, let's start with a question that really pertains, and you have, I think Casey's got the mic, so jump in as you feel comfortable answering. Can any of you all give us testimony or an anecdotal experience where you or your family member may have experienced a really exceptional level of health care from a nurse or specifically a care provider that you've been involved with?
Can y'all hear me okay? About 3 years ago or so, my daughter, who's now 15, she was having some breathing problems, and it was right around Christmas time. And we had gone up to Dallas where my in-laws live, and she kind of was getting worse and worse with her breathing. And we, I guess it was 2 days after Christmas or so, we decided to take her to urgent care because she was having so much difficulty breathing that we were really nervous about, her decline. And so we went to urgent care, and her O2 sats were like in the 80s, like mid 80s. And so they took her by ambulance over to Louisville, the medical center of Louisville. And of course we were away from home because we were, visiting my in-laws at Christmas. And I would say from the beginning of that experience, she ended up being hospitalized for 5 days after that, but it was completely positive. She ended up she had to get chest physical therapy, respiratory therapy, and supplemental oxygen. The alarms, were going off all night, and my husband and I were taking turns, spending the night there with her. But the nurses there on the unit were just amazing. They went out of their way to take the time to understand her and what her fears were, and her anxiety about being there. Once she became comfortable, because of the nurses making her feel comfortable, she thought, oh, this is fun, to be in the hospital. But one thing in particular that those nurses did was they bought a stuffed bear and brought it into the room and showed her, how to put the oxygen on the bear. She had this really cute picture of her, putting the oxygen on the bear, the nasal cannula, and talking to the bear about, this will help you breathe better. And I just thought, wow, they didn't have to do that. I don't know where that bear came from, if it belonged to one of their kids or they went and bought it, but they did that so she would understand what was happening. And so that was an extremely positive experience that I'll never forget, their compassion in helping her through that.
I'll echo some of the same thoughts. We've always found the nurses is what made a good hospital stay versus a bad hospital stay. We've only had good experience with the nurses, and I think part of that is because they're the ones who get to spend a little bit more quality time with the patients, especially in today's environment and the way billing works and everything. It seems like the doctors come in and out, right? They're not building any type of relationship. And I think in a scary situation where you don't know what's going on, having someone, if you're there for 3 or 4 days or 3 or 4 weeks, seeing the same faces and developing some trust in a relationship really helps the experience. And I give the nurses we've dealt with just a a tremendous amount of credit because they spend that time developing that relationship.
Any other panelists want to provide any testimony?
We had a similar situation with kind of an emergency situation where my son had pneumonia and was at a satellite hospital in Houston, and the nurses were really amazing. And in fact, a nurse was the one that really noticed he was not doing well and that he needed to go to the medical center. And she made the call to the doctor and really set him up for success in getting into the ambulance and telling him what was going to happen next, and all of us, in fact. Just very kind and compassionate, and making the call of that, he needs to be in ICU in the med center, and he spent the next 3 or 4 days in ICU, in a total of 10 days. So I really credit the nurses for just monitoring his situation, realizing when he was going down.
I think the thing I remember most, a situation with a nurse, was actually when Blakely was first born. And I did not know ahead of time that, he's heard this story before. I did not know ahead of time that he was going to have Down syndrome. So I think my husband and I were in shock and in fear, and he knows. I'm not hurting your feelings, right? I came around. A lot of crying, but he had to go. He was quite a big baby, but he wasn't breathing very well. He was pretty blue. And so he had to be in the NICU for a while. And the thing that I remember most is there was a nurse there who actually was the mother of a child with Down syndrome herself. And she was not on duty. She came, they probably called her and said, "We got this mom here who's a mess." And she took her own time, drove up to the hospital. It was not her time to be at work. And just sat with me and talked to me about her own daughter, who was, I believe, 10 years old at that time. And just saying, "This is going to be okay. I know it doesn't feel that way now, but you're going to make it. You're going to love your baby." I went through a period of thinking, but how can I love him? I could barely hold him. And she sat with me and said, "I've been where you are. I know how you're feeling. You're going to be okay." And I just thought that was amazing, especially since, she wasn't even supposed to be there. She drove up there to be with me. And I thought that was amazing.
Lex, do you have anything to add? It is. Thank you, Lex.
For all of us. So I appreciate the question. I appreciate the answers that have been given. They're very appropriate. I think mine dates back further than any of yours, I'll bet. I've lived through 2 deans of nursing at the University of Texas Health Science Center, so I've been around here for a while. The incident that I want to tell you about occurred on January the 14th, 1968. My neck was broken in a car accident on November the 20th, 1967, when I was a freshman in college. And I was taken to a hospital in Oklahoma City, St. Anthony's Hospital, and I was there for about 4 weeks before I was moved to Houston, to TIRR. But the experience I had there was actually quite a good one, because when I left the hospital, the day I was to be transported, a nurse who had been caring for me said to me, "Lex, you're going to be okay, but you need to learn to communicate clearly to people what you need. And that lesson for me was profound. Just so I don't have to back and forth with the mic, I think there's another question. You have one transposed with the other. Good nurse,
Exactly.
bad nurse,
Where we
kind
can
of a story.
improve.
So let me just flip it a little bit. I was confronted with a situation a few years ago when I was a patient at St. Luke's Hospital, and I needed to have an IV, and the nurse kept trying to give me this IV, and I said my veins are hard to reach, and you'll have to use a PD set in order to do that. And she said, the order for this particular medication, I can't use PD. I'm going to have to use this size needle. And so she started to stick me, and she couldn't get it in the arm. And then she said, we're just going to have to put it in your vein next to the heart. And I said, no, if you do that, nobody's going to be able to help me into my wheelchair. It's going to be impossible for me to be mobile at that point. And she said, but that's the only way we can do this. So just be quiet. And fortunately, there was another nurse who was there, and she stepped out quietly and got the cardiologist, who came in and said, stop that. And she stopped, the cardiologist stopped the nurse from doing that and said, we'll change the protocol for this patient. You don't need to use that size needle. We can do this procedure instead, and it'll be no problem. Good news, bad news. Thanks.
Thank you, Lex.
I'll come back and you can remind me, because I don't remember what you're talking about. I think what she's talking about is the transition from being a child to being a young adult. And Allison has a baclofen pump that she gets taken care of at TIR. The pump failed, or actually it was a different thing. She had a colon blockage, but we had an emergency. We drove up to the medical center. Now driving in the driveway, and Texas Children is to the left and St. Luke's is to the right. And she's 22. And I'm thinking she's too old to go to Texas Children, but those are the doctors and the nurses that I know we like, and we faced a real dilemma of where to go. I called our pediatrician, who's a good friend, and we were actually in the emergency room at St. Luke's, and she said, I can't treat you over there, but if you wheel her out and take her to Texas Children, I can see you. And it was a great experience because the nurses at Texas Children, nurses everywhere are compassionate, but I think from dealing with children, there's again, they spend a lot of time, they know how to talk to people, and there's just a fear among patients in that transition about being lost as an adult. Dr. Camere can talk about, that's kind of the role of the Texas Transition, the Baylor Transition Medicine Clinic, to help with that transition, to help train parents to let go a little bit so that their young adults can make decisions by themselves, and for the patients to learn how to transition.
I think that's a great feedback. Dr. Camere, I'd love for you to address what you all do at the clinic to help that transition.
Sure. I guess when I was hearing people's stories about the good experiences and the bad experiences, from being an inpatient doctor, which I don't do anymore, but I felt like when the nurses that I remember fondly, both with neurotypical patients and also with patients with disabilities, were really strong advocates for their patients. They were not nurses that just agreed with whatever I said, no matter what. They actually advocated for their patients. And so I think, especially in the setting of patients with any kind of disability, they really are kind of a mediator between the patient and the patient's family and the physicians, and that their job really is to treat the patient, but also to advocate for the patient, at least the way I think about, of course I never went to nursing school, but that's how I think about being a nurse. And so I guess when I think strongly of the good nurses, they were nurses that listened to what the patient was saying, listened to also what their family was saying, and didn't, would come back to me and say, hey, you ordered the medicine scheduled for this time. Mom says, like, that's just not going to work. And didn't sort of tell mom or patient to be quiet, kind of as that other example showed. Instead, they spoke up on their behalf. So I feel like that was what I would share as a good thing, that good nurse example. And then as far as our clinic, so our clinic, basically the transition is scary. A lot of patients have had the same set of doctors and nurses and physical therapists and occupational therapists and just huge teams that have taken care of them often from birth. Especially in our area, people come to Texas Children's and they stay. And so I think there is a lot of fear associated with that transition, but it is something that, you know, has to happen. And so our clinic, I think we treat patients that are 18 and older that have physical and or intellectual disabilities. And then what we're trying to do is basically help them start to navigate the adult healthcare system. And it's not something that's done quickly. It's something that's kind of slowly done over time. And sometimes it takes several years to find new specialists that they need, or maybe they don't need anymore. And so that's what I think is really fun about our job, is that we get to kind of be on a journey with the patients and their families. And it takes time, but it's neat because it's a relationship. So I don't know if that answered your question about what we do.
It does.
But, yeah.
Comes the tough question. What can we do as nurses, as healthcare providers, to improve? Can you give us testimony, anecdotal? It can be as negative as you want. And Jason, I know you've probably seen a lot in outpatient as a manager. So, but please, as a parent advocate or as a patient.
So I won't tell any horror stories, but I see a lot of nursing students here, and I'll give you a very practical example, and much like Lex did to compare both questions. I was a patient myself at the VA maybe a year and a half ago. I had pneumonia. I had a horrible fever, and I was right at the edge of being completely delirious. And the first time nurses came in to do the change of shift, I looked up and they were talking about me over my bed. And I'm like, oh, that's what bedside reporting is. And that sounds like, that's wonderful. And I was like, they do that here, that's great. And come to find out, subsequent shifts, bedside reporting wasn't done. And so they had a demonstration of a best practice. And unfortunately, either because of whatever situations were there, that wasn't consistent across what they did, and it was such a big difference from an experiential standpoint as a patient to say, this is really the best way to do this. So fast forward a few months, the graduate nurses at TIER had a project where they were going to investigate bedside reporting to figure out if it was a good thing to do. Was it a good thing to do at rehab? Was it a good thing to do at TIER? And the presenter of the research came up and said, yes, bedside reporting is fantastic. We should be doing this. And we do think it's the best practice here at TIER for rehab patients. And we're in support of this happening organization-wide. And I put the poor lady on the spot, and I asked her if she was ever put in a position to do handover of shift without taking a bedside report. And she said yes. And again, I challenged her. I said, well, why as a new nurse are you already accepting something that's not the best practice? And she kind of sat there like, oh, who is this guy? But I think that brings to a point, and the doctor at the end, she just made it. Put that patient at the center, focus on best practices, and you're going to have great stories to share, and people will share great stories about your care.
So my situation is interesting in that our son, of course, lives about 60 miles away from where we live, and we had a situation where our son had to go to an emergency room, and we're having to have medical conversations over the telephone, and is it necessary? What are we doing, et cetera, et cetera. So we couldn't get to see him until the next day. We couldn't get up there, and we get there, and I think in terms of what you were saying about the best practices, he really had an incomplete assessment. They had not followed a pain assessment protocol for someone who's nonverbal, which Robert is, and they had not assessed or even his ability to eat. They had not asked us as his parents, and we're so, just so emotional that he's had to go to the ER, and it ended up being something very, very minor. And so he was, I guess NPO is the term, for 24 hours, because they had to get a speech therapist to come in there to assess his level of ability to eat. So, I would say follow your protocols. Don't cut the corners, right? Have a complete assessment, not only the physical health piece, but that social emotional piece is so important, especially for our family members who have disabilities or developmental disabilities, especially for our folks who have developmental disabilities. So. That's a great question, Dean Frazier. I think, yes, I think perhaps there was some, I don't know, I won't say it's confidence, but yeah, and also Robert uses a wheelchair and he can't position himself, so they had not even put a positioning protocol in place.
I just want to make 2 points. The first one is don't make assumptions as a nurse about what someone can't do or can do. Because I've seen that a lot with my daughter is, she is verbal, she's friendly and everything, but she doesn't understand necessarily what is being asked of her. So she's, yeah, but I know that she doesn't understand it. So you kind of have to go beyond the surface. Talk to the parents, try to dig deeper, like what do you like? What are your fears? Like, for example, my daughter is very scared of thunderstorms. She's 15. Every night when she goes to bed, Mom, thunderstorm tonight? Like, nope, there's not a thunderstorm. But it kind of rules how she looks at things. And if she was in the hospital, I mean, I would be with her, but if it was storming outside and she was frantic, you would probably think, what's wrong with her? But you might not know it's because it was storming outside. You have to ask a little bit more deep questions than you might on your typical patient, is one thing I want to say. And something else is really important for just in general, but especially as a healthcare professional, is your reaction. Like, let me just kind of give you some background. I have an identical twin sister. We've always been very close with each other. When I found out I was having twin girls, I'm thinking, wow, they're going to be like we are. Well, they are very close, like they're fraternal, and one has Down syndrome. But when I tell people I have twin daughters, one has Down syndrome, imagine the difference in how I feel when I tell someone that and they say, oh, I'm sorry, versus, oh, wow, what kind of relationship do they have? What are her interests? So, have a reaction that's at least neutral. if not positive. And if you have a reaction that's like, oh gosh, I'm sorry, it's so deflating to us as parents and to the children who are magnificent in their own way. So just dig deeper, don't make assumptions, and don't make an error of omission, which is, assuming that someone knows or doesn't know something when it's, sometimes easy to find out or easier than you think.
I was just going to actually build on that, and that is prejudices and assumptions. So this not only goes to nursing, but just life in general. I know I've heard Allison say, I've heard Blakely say, one of their pet peeves is you go to the restaurant and they'll say, what would your daughter like to eat? All right? Rather than asking her. So, when you're interviewing a patient, assume that they can answer for themselves until proven wrong. And ask them all the questions. Now, I can tell you, as a primary caregiver, there's a special symbiotic or a much tighter relationship that I have with Allison, knowing her body more than my other two children. So I can tell you, I think it's important to also ask the parents, because I can tell you if she smells different, if she's stiffer, if her urine smells different, if she's itchy, if whatever, because she shares that stuff with me, or I can see minor differences that I may not see in my wife or my other two kids, because you just share a lot more as a caregiver. And so I think it's important to get baseline information from the patient, how they feel, what differences, but also talk to the parents about what they've seen over the last couple of weeks, any differences in mood, physical attributes, or something like that.
When I told Blakely what we were doing tonight, he said he had one important thing he wanted to say. So, here you go. Talk on.
Okay, so, I liked it when nurse and doctors talk to me and not to my mom. I am smart and can tell people how I am feeling or what hurts if they ask.
Straight from the horse's mouth. Yeah. And I would add to that, absolutely, it is very demeaning when a medical professional comes in, looks at Blakely, and then turns and talks to me. And I will say, all the panelists were sort of talking beforehand, and I said, most of our experiences have been very positive. I've been very impressed how I think people are changing in our society. I think they're realizing this sort of things. I think our kids are making them realize. So more and more often that does happen. Nurses will come in and speak to Blakely, and they may look over at me, but they really do address him, which I think is awesome. We've had some good experiences. But I would add, as Richard did, I would also add, though, once you've done that, do also take seriously concerns of parents. My pediatrician, we absolutely love him, although we'll have to leave him now. We have to transition, so I hear. But one of the things, I'll never forget what he said to me. He said, don't ever be afraid to call me. I mean, that man answered my call in Walmart, in grocery stores, everywhere. He said, but don't ever be afraid to call me, because he said, I've learned over my 40 years of being a doctor, 99% of times, the mom is right. You've probably heard that in a million classes, but yeah, don't forget it. I think it's important. Moms and dads sense things about their children that, you may not right at first. So,
and I agree. And one thing that Mr. Rosenberg said, that there is a relationship that is different than I feel like the relationship that I have with my mom or dad in terms of my health care. And so everybody's already said the important stuff, but always first address the patient. It doesn't matter what the situation is. As a nurse, you always should talk to them and assume that they can understand what's going on. Parents will jump in and be like, they don't know what you're saying if that's the case in that particular patient. But you can always just address the patient, and you will be shocked at even patients that are nonverbal have ways to communicate with their parents or with other family members or their caregivers that you had no idea. The patients that sign, patients that have grunts and different noises and flip their hands for different things. And so there are ways to communicate that you'd be surprised by. And then absolutely, I feel like in this job, I basically learn from parents every single day when I go to work. It's amazing. I mean, I pretty much just say, what do you think is going on? And I almost always get like to the bottom of the whatever it is. So I think as a nurse, you first address the patient, you get everything you can from the patient, and then in patients that have any kind of disability, you also address parents. But that's also true in older adults. You talk to their children, you talk to people around them. So I think a team approach is really important.
So the assumptions that I think it's been the trend that healthcare providers are making, do you feel that they're stemming from a lack of confidence, a lack of skills on the part of the healthcare provider? Where do you think these assumptions are coming from?
Just to make another example, in nursing school, I think what's drilled in clinical instruction is be careful about your license, or don't do that, or you'll have to worry about your license. And I think if we changed that habit and did something more like develop a questioning attitude, communicate critically and clearly, look for the best evidence, we'd never have to ever mention a license again for nurses.
I just thought back, I don't know if any of you are planning on working with new moms in that situation, but just we were talking about things that can be negative. The nurse who stepped up and really spoke to me was incredible. But the other side of that was, I'll never forget that first night, and my husband had to go home because we have an older child, and they had brought Blakely to me, and I was just holding him and was just very numb and very in pain. And this one nurse, I'll never forget, she came in and she literally would not look in my face. And I know, I'm sure on the floor when a child is born with a serious disability, people feel bad, and I'm sure there's talk, and but she literally came in, handed me some paperwork, said some things, but she was like looking at the lamp. She would not look at me. So I would love you to walk away with the idea of, even when a situation is difficult and a parent is hurting, look them in the face, talk to them, make eye contact, even if you're uncomfortable. I don't know, I would have loved that. I would have appreciated that. Even if she didn't know what to say, it's okay, but look at me.
And as far as assumptions go, I think sometimes you got to realize there could be a disconnect between mental IQ and social IQ. Just because you have a disability or a low IQ doesn't mean you don't have the same sexual desires, the same aspirations to get married, the same aspirations to date, the same aspirations to have a wide group of friends, and that drives a lot of personal decisions. I think as you transition into a teenager or young adult, it's important for doctors and nurses to spend time away with the patient, away from the parents, because the patients may be embarrassed to talk about stuff in front of the parents. So I always make a point of leaving the room and saying, y'all talk without me. I think sometimes parents need to be trained to step back as well.
Excellent.
Allison's laughing in the back. I don't want to hear anything else.
And so I just to kind of build on what everyone else is saying, obviously, whether you're working and choose to work in the industry of developmental disabilities or disabilities or not, there is a wide spectrum, right? And just as we all decide we want to live in a high-rise, or we want to live in a single-family home or a condo or on a farm, people with disabilities and developmental disabilities have those same ideas, right? And I think there are assumptions, and our case is a very good example of if your child chooses, or you choose for your family member to go and live at a state-supported living center, or they go live in a group home as opposed to living at home, don't assume that the parent or caregiver doesn't care because their child is living somewhere else, if that makes sense, right? Just because your child's living in a group home or a state-supported living center as opposed to living at home doesn't mean that you as the parent don't care about the quality of their care.
Excellent feedback, Lisa.
To also address what we were saying before about like what are some reasons why people maybe don't go the extra mile. I know as a therapist we have productivity requirements that we have to meet, and so sometimes we're rushing, and you know those patients that we have that don't hear as well, or there's some reason why the communication is more difficult. You know, we do tend to kind of feel frustrated, like, oh, you're going to take extra time, you know, now I've got all these other patients to see. And same with nurses, you have a lot of patients, and you know the patients that are real easygoing and you know they don't require a lot of time, like, oh, you know, thank goodness I have this easy patient. The ones that are more challenging, though, I mean, you still have the same ethical responsibility to take care of them the best way you can. And sometimes, you know, I've always heard communication is the secret to any successful relationship. Man and wife, siblings, friends, good communication is the key. It's the same thing with patients and caregivers. If you have a way to communicate effectively, then, you know, chances are the caregiving and the care receiving is going to be much more of a positive situation. As an OT, that's one thing that we, you know, kind of look at closely is how can we help people communicate with nursing staff, like call lights. People can't always use a call light. They might need some kind of adapted call light. They might need a telemetry lead with a little, you know, the little peg on there to feel where the call light is. Little adaptations like that can make a big difference for people that can't communicate in a typical way. So you kind of have to think outside the box a little bit in order to do that.
I would just like to add, you know, in an undergraduate nursing program, we sporadically are exposed to disabilities, children, adolescents, adults, and geriatric. And what we're trying to do is integrate more of that disability education at all levels, all ages. Do you feel like those, I'm a firm believer, and I don't want to introduce bias, but I think with clinical experience and exposure, it would raise the level of confidence for the nurse transitioning to professional care when she obtains her registered nurse, or he obtains his registered nurse license. The competence is increased, the communication skills are improved, the assessment skills. If they experience those patients with a wide range of disabilities in the undergraduate curriculum, do you feel like it would improve their communication and assessment skills once they transition to a professional nurse?
Thanks, Casey. UT does a really great job at efficiently taking nurses, and absolutely, would they have better assessment skills, especially if they're working with patients who can't speak, can't move. So exposure to those patients is important. But the core, I think, of UT's nursing program really is fantastic, and maybe integrating with the acute care GN programs should really be the long view of nurse education. Like, nobody should leave UT or Texas Women's and kind of hit the street running as a nurse. And if you kind of think of that long view and making good connections with the educators in the major health systems, certainly they're going to have more opportunities maybe than they can have in the or with UT.
Good point. What role care provider do you find is most helpful with care coordination or long-term planning?
So it's actually, my position is a little interesting because advocacy is the number one thing that I try to communicate and educate not only patients on, but healthcare providers as well. And that balance is very difficult. It's so incredibly important to teach someone who has acquired a disability or has acquired a new body, say the sense, and teach them how to best communicate not only with their family but with their healthcare providers. I am a medical assistant. I love the position of nurse liaisons in the same sense, like cancer, any other type of disabilities as well. Those nurses help patients navigate the healthcare system. They teach them how to communicate, where they should go, where their best resources are, and that is completely invaluable. I wish I would have had someone like that at the time that I was going through my trauma, and I try to make sure that my patients have a voice. If I could sum it up easily for nursing students, it would be advocacy, communication, and support. I mean, that's what you're there to do. My best experiences were with my nurses, and they advocated for me, whether it was against other nurses, like Lex's particular situation, I had something similar, and my nurse was there to advocate for me. When I'm in outpatient clinic, healthcare providers tend to forget certain things, so I'm there to remind that healthcare provider, hey, this is what this patient is psychologically going through. This is what I experienced as that patient. And it can be vital to teach not only doctors, you're gonna end up meeting other residents who you have to educate. You're gonna educate each doctor that you work for. So I just always communicate and be your patient's advocate.
So in adult care, it's very common to see poor health literacy in a long-term or severely injured adult. And I think one of the best systems for that care is actually in the workman's comp system, because those heavily injured long-term patients have a case manager quarterbacking them all the way through the health system, and the fragmentation really falls apart. And there's somebody there who can always answer questions or has a long-term association, very much like the parents up here and their children. And that's a very unusual part of the healthcare system. And unfortunately, it's because that's the one place that's really funded. And I think if we saw that in a broader aspect, that case manager not just doing utilization review or discharge planning, but actually following that patient, we'd have a lot of different healthcare outcomes in this country.
I think that's really important too. I can tell you, when Allison was first born, we spent 4 months in the hospital, and initially we didn't know she would have all these problems. We picked a pediatrician who was part of a group of 25 pediatricians. So every day there was a new pediatrician rounding, and every day the new pediatrician would come by and say, "Did the gastroenterologist come by?" Like, I don't know, look at the chart. He did. And they asked me, well, what did he say? I was like, I don't know, I'm not a doctor. We ended up switching pediatrician groups after 3 or 4 weeks and found a group with 3 people so that someone could be a quarterback and a patient advocate. And we found that invaluable. So I think especially on complicated cases, you need someone who knows the history and whose partners know the history, so that you don't have to get everyone up to speed, which takes a half an hour and all that. And,
That's right.
So having a quarterback is invaluable.
Excellent.
I'd like to add to that, quarterbacks are not always the team's favorite person all the time. Okay, I will say that. So finding that balance between educating the patient, educating the healthcare providers at the same time can be very difficult, but it's definitely a very vital position that you have to play.
Do we have other questions from the audience? best healthcare system with so many competitive places? Lex, do you have any input? Okay, let's run that mic up to Lex. Thank you, Angela. How do you choose the best healthcare system with so many competitive places?
Could drop a bomb here if I wanted to, but I don't. First of all, the best place to go in the Texas Medical Center if you're a person with a disability is TIRR, T-I-R-R, TIRR Memorial Hermann. That's don't have to think long about that. And that's a personal bias that I have based on services I've received for now nearly 5 decades. So, and that's been consistent. But I would say that we all in Houston are fortunate because we can't make too many mistakes in choosing. We have a lot of great service providers and a great community of service in the Texas Medical Center and in Houston. But we all have differences and we all have different needs. And it's always been my experience that the people who can guide me best are people who have had experience in those places. So I talk to other patients and find out what has been their recent experience, and that's another thing. Tradition and awards that were given years ago or even a year ago are not very valuable in terms of judging the present state, because we have a lot of turnover in staff. And frankly, those facilities and programs, it's even programs within facilities, you simply can't generalize. I mean, we can all say, Methodist is a great hospital, St. Luke's is a great system, and so on, but that's not true. There are programs within each one of those organizations that are exceptionally good, and then there are those that are constantly in the process of transformation, and they're getting better, but not necessarily as good as some others. So I think we really do, when we're consumers, need to choose based on partly our own experience, but not always, because our experience, in my case, it's been 10 years since I was a patient at Hermann Hospital. Things might have changed on the unit that I was in. So if I had to go voluntarily and had the opportunity to choose, I would ask around. Sometimes you don't have the opportunity to choose. Your Medicaid managed care program or your health insurer, the program you have, will tell you where to go. We have this great dilemma with some people who want to go to MD Anderson and it's not in their plan, and other people who prefer to go to Hermann and it's not in their plan, whatever. Sometimes you don't have that option, so you have to be prepared to represent yourself and be a self-advocate when you get there. You have to know what kind of care to expect, and if you don't get it, have the courage to talk to somebody who can fix it. Each one of these facilities have advocates inside the facilities, people who are paid to be ombudsmen for the patients. And they're very well trained, in my experience, experts at what they do. And so it's important. If you're not getting good service, even though you have a good recommendation, maybe good experience, you need to talk to somebody who can help you solve the problem, because you're solving it not only for yourself, but for everybody else who's on that floor, that wing, and that hospital, or wherever. Just let me add, too, I think nurses need to be better advocates. I think we need to train nurses to be advocates, and not necessarily advocates for their individual patients. But let me give you an example. We have a horrible time in our hospitals now on discharge, because we're not always able to say when that patient's ready for discharge, and the discharge order may be written one day and the patient leaving the next. And what kind of planning can we do for them to get back into the community if we have one day and we have navigators who are there supposed to be placing these patients in the community, and they have a few hours? They don't have time to find accessible housing for them, to set up community-based care systems for them, even to set up systems that will help their family if they're going to be discharged home. Nurses can stop that. Nurses can say, this is hurting my patient, and we need to change this system. We need to have the time necessary to do the play. We need to have the staff necessary to go out and canvass the community and find out and keep track of where all the accessible places are, where all the places are that are actually giving good support and service, where all the caregivers are that can be employed that can help us in our home. And we don't have that now, and I think it's caregivers and nurses who, by their very nature, can be great ombudspeople. I would also say the nurses who wish to do that should seek partnership with advocacy organizations of people with disabilities. Because if we start talking for other people, and you all have mentioned that, then we're really giving up the empowerment that people have earned by being here on this earth at this time. So, I would encourage nurses and nursing schools to teach advocacy, to encourage advocacy, and to look at systems advocacy. And you have an opportunity right now because a woman, Mrs. DeVos, is being considered for the Secretary of Education in the United States. And she has pledged to change the rules that require kids in school to have appropriate education and to have plans for education in the school. It's too much paperwork, she says. It costs too much. The schools are too much engaged in it. I mean, what do we do about that? What can we do? What are we able to do? There are all kinds of challenges that come up in public policy. If we think things are working well today, I guarantee you they won't be tomorrow because people in Washington don't think very much. And that's the way it goes. But we can change it because when they make a mistake, they're obliged to represent us. In 1980, Ronald Reagan said he was going to carve away all the regulations that provided for access to schools by individuals with disabilities. He appointed George H.W. Bush, the vice president, to do that. There were 700 pages of regulations that supported education for kids in schools. Vice President Bush put together a task force. Parents of kids with disabilities around the country heard about it. They started writing and calling, and there has been no better advocate in the United States or the world, for that matter, than George Bush. He signed the Americans with Disabilities Act, and he pushed it all the way through. But his first experience, and the thing that caused him to do that, was his meeting all those advocate parents when he was tasked with ripping out the regulations to the Handicapped Children's Act. So, we as advocates have power, and we have it in the hospital when we're patients, and we have it in the community when we're citizens. Thank you.
Thank you, Lex. I think we have time for one more question from the audience. As an inpatient director, I have many patients that the appropriate transition of care was not recommended. For instance, spinal cord not getting rehab. Nurses at bedside need to be able to know how to advocate and understand other levels of care? ? What forum in nurse training would accomplish this knowledge? Exposure.
When I went to nursing school, I was very experienced in the healthcare industry. So I don't know if I can answer that question, but I will tell you, going back to it's a great job at creating nurses. One of the things I didn't see in nursing school was knowledge about the industry. So coming out of nursing school, I had experiences about, what was available on the market, and now I could save somebody's life if I had to. But I think my peer group was really very much in tune with, that early piece of nursing. So I would either, urge student nurses or urge educators to present at some place a broader view of the healthcare industry. The other thing I don't think nurses understand when they leave nursing school, care, and that drives everything. It unfortunately is not your skill as a nurse, it's not your heart as a nurse, it's the economics of all of the healthcare system. So I do think that needs to be highlighted to nurses, but how you add that into your curriculum, that is a challenge.
Any others to add? Okay, well, we are almost at 8 o'clock, and I think we'll conclude with that last question. And I just want to again thank the center for letting us host this event here. Thank you, Kevin. And thank you to Todd from UTAV for videoing this event. And thank you to all our audience members for again taking time, and our esteemed panelists for giving your time and your expertise and your testimony and your frank comments, which I really hope will help move forward more and improved clinical experiences for student nurses. So thank you. Let's give a round of applause.